I'm Dr. Prabhat. I'm Dr. Prabhat Nangia. I am a consultant in Cornea and Strabismus at Surya Institute, Nagpur, and I completed my FRCS ophthalmology Glasgow last year in Feb at Bangalore. I gave the first step at Bangalore. So today's session is going to be all about cornea. I've framed it so that you may look at typical images that are likely to show up in the FRCS examination. As it's pertaining mainly to the table viva, that will be cornea and cataract, but I am only going to focus on cornea. So can I know how many people have joined in so far? Because I'm not able to see
15.
that. All right.
15,
So
15. No, if you watch the participants link, you will see around 14, 15 people have joined.
all right. So it's all basically I've framed it the way it would be in the exam in terms of the fact that I'd like everybody to volunteer and take up one after the other scenario. So this is the first scenario: a 56-year-old lady who came with diminution of vision in the right eye with a little bit of pain. And can anybody describe this image? So the image to your left is in normal magnification and high magnification on the right side. Can I have a volunteer, please?
Dr. Prabhat, you can ask anyone. You see the names, you can ask anyone because if Dr. Faiz, please volunteer.
Yeah.
Yes. Hi, doctor. I am Dr. Wafa from Jordan.
Yeah.
I can see in the first picture on the left, I can see a stromal haze.
Correct.
On the other hand, it is not clear, but I think it is guttata or something like that. I'm not sure. The image is not that clear.
Hello, sir. Hello, sir. This is a Fuchs endothelial dystrophy, which reveals corneal gutte excrescences.
I mean, that would be a reasonable differential. But in this case, what we're looking at is a unilateral condition. Fuchs is normally going to...
So I would like to know what is the scenario of the other eye. Sorry, I shouldn't ask what is the other eye.
That's okay. You can ask me that. The other eye is normal. She's got 6/6 vision with early cataract changes.
Sir,
angle closure?
One second. Let's not collude together.
Can I?
Let's
Yes,
one
sir.
person. Yeah.
Yes, Miss. So I would like to ask Institute of Surgery, anterior segment surgery.
She has not been operated. Not been operated upon in the eye.
Okay. A unilateral presentation of corneal haze. It's unlikely to be.
I mean, haze is fine, but it's not the specific term that I'm looking for.
Okay, there is.
One second. Let's not do that. If whoever has started first, could you please continue if you can? Otherwise, the second person could take it up. Let's not come together because there are enough questions going forward.
Yes, sir.
Okay.
So I'm okay. I would just to describe. We don't know which eye it is, and I can see.
Right eye. This is the right eye.
Okay. And looking for grossly from outside, you can actually see circumcorneal reddishness, a reddish lesion.
You can call it
circumcorneal congestion,
yeah.
or could also be subcorneal hemorrhage. It's a circumcorneal congestion. Okay, sir.
Okay.
Yes, sir. Yes, sir. And okay, so this is a slit section, optical beam, and the second image is a higher magnification version, and there is a generalized cornea with how do I say, zigzag striae. Yeah, there are striae which are in multi-directed striae in the cornea. And
which level of the cornea?
In the stromal.
Hello?
Stromal level of the cornea, sir.
No, it's a little bit more posterior.
Subepithelial.
No. It's posterior. It's actually
endothelial. Oh, sorry. So, okay, endothelial. Okay.
So these are folds on the Descemet membrane. So in the interest of time, I'm going to move this along just a little bit.
Okay,
what
sir.
we're looking at is
sorry.
What we're looking at is not just haze. We're looking at corneal edema with membrane folds. And when you look at the higher magnification image, you're seeing keratic precipitates.
Yes.
All right.
Yes.
So corneal edema, Descemet membrane folds, and keratic
Folds.
precipitates.
Keratitis
Now,
precipitates.
if I add on one more finding, I tell you that corneal sensations in this eye are reduced.
Yes, sir. So I'm thinking of herpetic, actually herpetic keratitis.
Yes.
But I'm not able to comment on the cell. So probably could also be herpetic kerato-irido, uveitis, yes.
Exactly.
That can, And also I can also see, because of the circumcorneal condition, there's also some, there's a hint of some hyphema inside the eye. I'm not very sure.
No, I mean, it's just a light reflex.
Okay,
Because of the edema.
okay.
Yeah.
Okay,
I can understand why you're feeling like that, but there was no hyphema.
Okay.
So,
but I would also like to ask history of trauma also, so to be ruled out.
None. No
Okay,
history.
okay. Yeah, it's more in favor of viral. Yeah, I had it in mind. Yes, sir.
Yes.
Unilateral presentation.
So, when you have a patient like this, where there are corneal findings, that is corneal edema, Descemet membrane folds, in addition to keratic precipitates with or without antechamber cells and flare, very few conditions have keratouveitis, and therefore, and particularly that is unilateral, you probably want to think of a viral keratouveitis. So this is the case of viral endothelitis. So endothelitis will present with DM folds, corneal edema, and with or without keratic precipitates and antechamber cells.
So
All right.
Yeah, I would also like to do a gonioscopy to rule out trabeculitis because. But because the cornea is so hazy, I'm not able to. May probably do a gonio for the other eye.
What will you see on gonioscopy in such a corneal edematous patient? Will it be visible? Will anything be
not
visible?
Not in this eye, sir. But
on the other eye, what will you see? Other eye is normal.
If the other is normal, it's unlikely that I will see any findings, sir.
So what is the finding in trabeculitis? So this is
a mashed potato appearance would be there on gonioscopy.
But as of now, it is very difficult practically to see anything.
Yes, sir.
So it is better not to discuss this.
Okay.
Yeah,
sorry.
I mean, I was gonna. It's fine. Don't apologize. We're all learning here. So the idea is that don't say too much.
Sorry, sir. Okay.
The diagnosis I'm looking for is the diagnosis your examiner is going to be looking for.
Yes,
right?
sir. Okay, sir.
This is why cases are going to be fairly straightforward.
Yes.
All right, just above PG level is what
sir.
I would say. Now, the third and the final question: how would you treat?
Okay.
So, viral endothelitis diagnosis is established. How will you treat?
Sir, I would like to start a patient on steroids.
What steroids?
Prednisolone.
What? Oral or topical is what I'm trying to.
I would like to start on topical steroids.
Topical prednisolone, what?
Topical prednisolone.
I mean, and you can choose sulfate also, but you just say acetate because
acetate. Yeah, prednisolone acetate. Right? Yeah. Yes, sir. And also cycloplegic as well.
Okay, great.
Since it's deeper level, I would also probably not very sure about oral steroids. Also antiviral acyclovir.
Yeah. So
yes,
topical steroid, yes. Cycloplegics, yes. Oral steroid, no, not necessary. All right. And oral antivirals, which is what you mentioned, yes. Why? Because the herpetic eye disease study 2 clearly tells us that giving oral steroids
it reduces the chance of recurrence.
Reduces the chances of recurrence for abnormal and endothelial keratitis. So topical steroids, because they will fight off the inflammatory
element within the herpetic keratitis.
Faster resolution.
Faster resolution.
All right.
Yes.
And cycloplegics to stabilize the blood aqueous barrier.
Yes. Okay.
All right. I'm going to move to the next question.
Thank you, sir.
So you can just read through the answer. Slit lamp photograph showing corneal edema, DM folds, and keratic precipitates, likely viral keratitis, and topical steroids with oral or topical antiviral agents I have written, but actually you would give oral antiviral agents. So we normally in India give acyclovir 400 mg BD. All right. And
a question for candidates, especially from India, if there is a unilateral corneal edema, can any specific toxicity cause corneal edema, Descemet's folds? Anyone from India? Specifically during Mahashivratri? I don't think there is anybody from India. Dr. Anirban?
Sir, I am from India.
Yes, Anirban.
Yeah.
You see that there is unilateral corneal edema.
Yes.
After yesterday was Mahashivratri, so there is the profuse corneal edema. So what could be the cause?
So due to that, I can in the Bengali thing I forgot the. It's is that chemical, sir? I mean that that flower
that?
I mean
pink.
the
milk from the
of
plant.
that
Milk.
plant.
Calotropis.
Calotropis. So this is very common in India. It is something which is being used to worship Dr. Lord Shiva. So at least in West Bengal, we get a lot of those cases who have sudden onset, severe corneal edema, and Descemet folds due to that only.
Yes, sir. Yes.
Okay, please continue.
Just to complete the discussion, there as well, the treatment would be topical steroids predominantly, along with lubricants and cycloplegics. But there, of course, you don't need to give oral antiviral agents. Okay, so the second scenario, can I get a volunteer, please?
Okay, sir.
Yeah, please go ahead.
It's an anterior segment photo showing an circumcorneal injection and a photo for penetrating keratoplasty with interrupting suture and super corneal infection.
So very important point. So can you describe the let's just call it an infiltrate. So can you describe the infiltrate in a little bit of detail for me? Like try to make it more scientific.
Yes, infiltrates. I don't know which eye is this.
It's the right eye. The right eye.
Right. So it is temporal, near to the suture. It's about 5 millimeter and 4 millimeter, deep white, with the vascularization approaching the cornea, the limbus to the cornea.
Yeah, good enough. So just one additional feature that I want to describe in this case, that the ulcer is a little bit dry looking. All right. So that those are key terms that if you put in, if you're confident, then you say them. Otherwise, forget about it. All right.
And also, Dr. Deba, one suggestion, like do not ask which eye is this. So basically time is very precious and you have only 5 minutes with the examiner. Yeah. So just focus on what is visible, do not focus on what is invisible, what is not there. So just say what you can see and stop there. Do not speak more and do not speak less also. So this is, I do not know which eye is this. You do not know, that doesn't matter because the eye doesn't matter here.
Yeah, the
eye doesn't. Just speak very, very confidently, speak very precisely and use the time with your examiner to the fullest.
Right, wisely, yeah. All right. So these are the questions that I have. She described the image. So what investigations would you want to do? So you've got a corneal ulcer in a failed graft. What investigations would you want to do?
I wanted to do corneal scrubbing and do culture.
Wonderful, wonderful. So, so I'm not going to go into details of how you do corneal scraping that you can read up, but what are the tests do you want to ask for in the corneal scraping? So you send the corneal scraping. What are you going to tell your microbiologist?
Stain.
So what all you want? What test do you want the microbiologist to run as a standard? What do you want the microbiologist to run? Which microscopy staining and which cultures?
Gram and Gemsa stain and the culture on blood and chocolate and saprolite agar.
Wonderful, excellent. So gram, KOH, bacterial culture and fungal culture. So how do you do gram staining? And what is the agent of choice for filamentous fungal keratitis? So this is a case of fungal keratitis. So, but first you tell me how you do gram staining and then we'll go for the last question. Should I go ahead? You want to tell me how it's done? Yeah.
I cannot go ahead on this question.
Fine, no issues. So corneal scraping, as you mentioned, investigations. In addition, it's always a great idea to do the lacrimal sac syringing to rule out a local source of infection, and never forget the systemic status in terms of the diabetes. So check for fasting and postprandial blood sugar. All right. So as I mentioned, in terms of the corneal scraping, go ahead with a gram stain, KOH, bacterial and fungal culture. Sorry, my apologies. So how do you do a gram stain? You first apply to the slide, you first apply the primary stain, that is crystal violet, to a heat fixed smear. And then add iodide, which binds to the crystal violet and traps it in the cell. All right. So crystal violet is what is blue. All right, which is grams. That will make it grams positive. So the iodide will help retain it in the cells. Then you decolorize the slide with ethanol or acetone. And finally, you counter stain with saffron, which is what gives it the pinkish hue. So gram positive will stain blue because of the crystal violet, and a gram negative will stain pink because of the saffron. All right. So the agent of choice for filamentous fungal keratitis is topical 5% atomizin eye drops, as clearly proven by the mycotic ulcer treatment trial, or MUT1. So the third scenario, this is, can somebody volunteer for this, please?
Okay, I will do.
Yeah, that's the same person. Is the same person who volunteered for the previous question?
No, no, no.
All right. Sorry. Please go ahead. My apologies. Yeah.
I'm Dr. Arshi.
Yeah. Please go
I
ahead.
will try to answer your question.
Please do. Please do. Yeah.
So, this is a slit lamp picture of cornea
Hmm.
showing the endothelium layer,
Yes.
and there are looks like some have a corneal guttata.
Hmm.
Most probably, this is a case of Fuchs endothelial dystrophy.
Hmm. Fine. So then I'll ask you, what else would you want to see in
Well,
terms of
like
evaluation? What else would you want to see?
so, I would like to see the corneal thickness.
Yes.
Visual acuity is the first thing that I would like to see. I would like to see the cornea on the slit, in the slit form, and also in the specular reflection
Sure.
way
This is
to
already
check the.
specular reflection. This is already specular reflection.
Yeah.
That's the only way you will see the gut in such detail.
Okay.
All right.
And yeah, yeah.
So
Okay, and yeah, and the corneal thickness, pachymetry is important in this.
good.
And then is when we do the specular count, that is also important to
Okay.
see the if there's any pleomorphism, what is the number of endothelial cells, the status of it, and yeah, and the IOP is important.
All right. IOP. All right. IOP is important in general, also because Fuchs and angle closure disease have a close association. But
Yeah.
one thing that I would have added is that I would have looked at the other eye for gut,
Yeah.
because
Yes.
it's a
Other eye
dystrophy.
is
It's a
important.
bilateral
Examine.
disease. All right.
Exactly.
Now,
It's a corneal dystrophy.
what does the patient with
So it is.
early Fuchs dystrophy complain of?
Early Fuchs, they mainly complain of decreased or blurring of vision, especially in the morning.
Why?
Because that is the time when the two factors also work while the person sleeps. First of all, there is ischemia, and then the corneal edema can happen because of that, and then the endothelium count is not enough to take out the corneal the fluid from inside. Then also the endothelial pump is not working, and it is seen that early
Yes.
morning.
Yes. So the endothelial pump is fairly inactive, or compared
Yeah.
to daytime, at night, it is fairly inactive, which is why there is fluid retention in the cornea. Therefore, they have morning blurring of vision.
Yeah. Okay.
So you have correctly identified that these are guttae. So if these lesions are only seen in the periphery of the cornea and are associated with increasing age in an otherwise healthy cornea, then they are not actually guttae, because guttae are first seen in the center, then in the periphery. So guttae-like
Okay.
lesions seen in the periphery, not seen in the center. What are they called?
They are called yellow. That is excrescences. That is called as I am
It's fine.
forgetting the
So
name.
you mentioned, we'll go to the third question. You mentioned specular microscopy and pachymetry.
Yeah.
All right.
Yeah.
And finally, what are the measures for a patient like this? Let us say that
Yeah.
you have a count of, say, 550 and
Yeah.
I'm sorry, pachymetry of 550 microns and an endothelial cell count of 1500.
Yeah.
So you go ahead, you plan for clear corneal phacoemulsification. Now, are there
Yeah.
any additional measures to protect the cornea and prevent decompensation that you should take during cataract surgery?
Yeah. So for that, because the count is although the corneal thickness is 550 micron, you said, right? So it's not above 600, and the counts are also not so low
Yes.
that we can plan out DSEC along with the cataract. So it doesn't need that way. But yes, we have to follow some precautions. That
Right.
is, we call as soft shell technique in the cataract surgery. So in that we will make the scleral tunnel, and we keep the phaco probe. While if we are doing phaco, we keep the phaco probe inside most of the time. We put lots of visco dispersive material to underline the corneal endothelium, so we don't traumatize more the endothelium layer. And we keep all the parameters at the lower side,
Yes.
less energy to be used.
Yes.
Yeah, and try to be slow in the cataract surgery. We shouldn't do it with a very fast, so we don't hurt it.
Okay.
And yeah,
So
and IOL should be put in the bag. It should not never be tried to put in the anterior chamber in these patients.
okay, great. Only thing I'm not very sure about the scleral tunnel part of it. You can just read up on that. But
Yeah.
she mentioned these are corneal guttae. If they're seen in the periphery and associated with age, they are known as Hassel-Henle bodies. These are non-specific
Yeah.
degenerations, all right, not dystrophy related.
Yeah.
So
Yeah.
specular microscopy and corneal pachymetry are the tests that you'll do. And during cataract surgery, dispersive viscoelastics to coat the endothelium, use of low flow parameters, low phaco energy in the bag phacoemulsification, and using solutions such as BSS plus, which contains glutathione as an antioxidant and is endothelial protective.
Okay. Yeah. BSS plus glutathione.
Yeah. So can anybody describe this investigation and tell me what you're seeing here that is different? Let's move it along, please.
This is topography.
Yes, wonderful. So right and left eye topography. Can you describe what you're seeing?
It is showing the flat cornea. The steepest even is 38.48 and the flat one is 37.48.
Yeah.
So it is like the steep cornea in both the sides. And there is astigmatism of 0.99, eccentricity is, yeah. So basically it is a steep cornea,
Steep cornea.
topography. Sorry, flat cornea topography. Yeah.
Wonderful. Flat cornea. Okay. So the flat cornea with K values of 37 and 38, this is a kind of cornea you are likely to see in patients post myopic laser vision correction. So you're likely to see this after myopic LASIK, all right, or myopic PR.
Yeah.
You're likely to get something like this.
Yes.
So volunteer, please, for this slit lamp image.
Yes, sir, I can take it.
Yeah, please.
Okay, it's anterior segment photo of the left eye, most probably showing elevated limbal lesion with mild hyperemia around.
Sorry,
It's for
you said
differential diagnosis.
elevated lesion with mild hyperemia. All right.
Yes.
Okay. What else?
I see telangiectasia around.
So it's a 40-year-old lady who's been complaining of rapid growth of this mass over the past 3 months and has now come to you for evaluation and further management. There's no other history of any surgery or any other intervention in the past.
Okay, it's for differential diagnosis. It may be ocular surface squamous neoplasia.
Wonderful. But you try and describe it a little bit more.
Okay. Other differential diagnosis may be tracheum, maybe binguocular.
What was the differential that you mentioned?
Other differential, it may be tracheum or binguocular, but it's most probably ocular surface squamous neoplasia.
Okay. So I'll try and describe this for you. All right. So this is this was a temporal mass in this side, temporal conjunctival mass that is abutting the limbus from 8 to 10 o'clock, all right, or 8 to 11 o'clock.
Okay.
That is, so when you compare it with the cornea next to it, you can clearly say it's about 6 by 5 mm in size, and it is an elevated mass with a leukoplekic component. So the whitishness that you see is a leukoplekic component. And further temporal, you see some vessels that are climbing onto the mass. Those are feeder vessels. All right. So the feeder vessels are what provide the ocular surface squamous neoplasia. It's nourishment. So you described the image. We've had the diagnosis. So how would you investigate, and what are the management options available?
Investigation, we can do anterior segment OCT or UVM to investigate more of invasion of this mass to the ciliary body or to the angle of the eye.
Correct.
After that, we can take surgical excisional biopsy.
Okay. Are there any non-surgical options available?
UVM and the anterior segment OCT.
Those are investigations. In terms of the management, do we have any non-surgical options?
Okay, I can take surgical excisional biopsy with safety margin 2 to 4 millimeters, and I can add adjuvant 5-fluorouracil or mitomycin.
Okay, that's quite good. Yeah. So so you can do, of course, you have to do slit lamp photography. Impression cytology can be done to look for dysplastic epithelial cells, but remember that in impression cytology, because it only rubs off the surface cells on a nitrocellulose and evaluates only the surface cells, cannot differentiate between a carcinoma in situ and an invasive squamous cell carcinoma. Gonioscopy to rule out angle involvement, ultrasound biomicroscopy to rule out scleral and angle invasion, and anterior segment OCT also to look for angle invasion. But the difference between UBM and ASOCT in this case is that UBM will show you whether or not there is scleral involvement and ASOCT will not. However, ASOCT will show you much finer details, such as there is always an abrupt transition from the normal to the dysplastic epithelium. So that is picked up beautifully on ASOCT. That is not going to be seen on the UBM. So these are the features that you look for. So when you order an investigation, ideally you should know why you're ordering it. And therefore you should order that investigation accordingly. So in terms of the treatment, you can use topical mitomycin. 5-fluorouracil, of course, is also a good option, or topical interferon alpha 2B. Surgical excision with cryotherapy to the conjunctival edges to kill off any residual cells in the margins, with amniotic membrane grafting to cover the bare sclera. So that would be the complete surgical management. So this was a 37-year-old male patient complaining of pain in left eye. This image is the image in green is from the left eye, and the images above are the right and left eye respectively. And he has diminution of vision in both eyes. 612 in the right eye and 636 in the left eye. Do you have a volunteer?
Okay. Is it corneal dystrophy, lattice with the mixed alveolino type, maybe lattice and granular mixed corneal dystrophy?
Okay. So, I mean, avellino is a very specific diagnosis. Can I ask you why you thought it was avellino?
Actually, I can see the lattice types of lattice type, and then there are some dotted. So I thought maybe this would be because there's a mixed one.
I mean,
so
I would keep it very simple if I was your examiner, and I would keep it very simple if I was appearing for the FRCS. If you're seeing lattice, it's lattice. The probability of an examiner putting up an avellino is a little less. But it's great that you've read about avellino, so then you know everything about dystrophies. But coming to this this image in question, this is a lattice dystrophy. With right and left eye, there are they're called refractile lines. All right, refractile lines that are seen based on retroillumination. That is why I put up the retroillumination slides. Now the dots you're seeing, they are irregularities that happen in the epithelium. So the lattice dystrophy, as per the recent classification, is an epithelial stromal dystrophy. It's no longer an exclusively stromal dystrophy. That is a recent classification from 2015. There has been no update since. It's an epithelial stromal dystrophy because it also involves the epithelium in different kinds of ways. Now, why am I seeing a defect in the left eye? Why are we seeing a defect in the left eye?
Yeah, because of the corneal edema. epithelial edema has happened, and it has led to the sloughing of the epithelium, leading to epithelial defect.
So edema is not the right term. The right term here would be that it leads to erosions.
Oh,
The
yeah.
lattice
Corneal erosions,
dystrophy
yes.
patients or eyes with lattice dystrophy are prone to recurrent corneal erosion. It's one of the common causes of recurrent
Yeah.
corneal erosions. All right.
Yeah.
So
Yeah.
so how would you treat it in the acute phase, and how would you treat it once the defect heals?
Okay, so in the acute phase, when there is a corneal, like if there is a
You've got a
erosion, then
defect.
for that,
So you've got a defect. So how do you treat the defect?
defect.
Is what I'm trying to
So
ask.
for for the defect, we can use the 5% sodium chloride along with the antibiotic, lubricants, and we can give bandage contact lens.
Okay.
That will help in the pain and cycloplegics.
Why 5% sodium chloride when the defect is there?
Sometimes it's corneal, corneal. I mean, if because the cause is the edema, which is causing the erosion, so this the sodium chloride, it helps in the improvement in corneal edema, and then it heals faster.
So I would avoid the sodium
Yeah,
chloride when the defect is present. I would first heal the
is
defect,
there.
and then I would
Yeah,
use sodium chloride ointment or drops to prevent further recurrent
yeah,
erosion. So let's remove
yeah.
sodium
Okay,
chloride from the equation for now. You have a defect.
okay,
You mentioned
okay.
lubricants. You mentioned something else.
Yeah, cycloplegic bandage contact lens,
Wonderful, wonderful. Okay.
BCL,
So
and antibiotic lubricants.
okay,
cycloplegics.
okay. So you have healed the defect because of with bandage contact lenses, lubricants, topical antibiotics. And now the vision is 612 in one eye, and it is 24 parts in the other eye because of so it's important to understand that in lattice dystrophy, the lattice lines alone do not cause a diminution
Yeah,
of vision. There is subepithelial
yeah,
haze that sets in that also causes diminution of vision. So now the patient has
yeah,
extensive lattice dystrophy with 624
yeah.
parts vision. So what are your management options then to improve the vision?
So what we can do is to we can do epithelial debridement and let the fresh epithelium grow. Sometimes
Yeah.
we do this thing, but
That is
not
for
after scarring. Yes, that
that
will
is for
not be in
recurrent
that in the
erosion.
acute phase.
That is for recurrent
Yes,
erosion. Your defect has,
yeah,
once again, I want to ask
yeah,
you, you're now talking about visual rehabilitation. So what are the options
yeah.
in a patient of lattice dystrophy for visual rehabilitation?
So we can give intrastromal punctures.
Intrastromal punctures increase the scarring.
Yeah,
You're
that
thinking
will
again
help
now
in
about
the
recurrent erosions alone.
Okay.
So forget the defect. Yeah, I'll get rid of the image. I want to give
Okay.
vision to this patient. I'm an ophthalmic surgeon and I want to give vision to this patient.
Okay, so we can try the glasses and
Good,
um,
not bad.
and try with the contact lens, and in the end I'll go for keratoplasty if it
Okay,
is not improving.
sure. Yeah, so that would work. So what is the inherent pattern of a lattice dystrophy?
All are autosomal dominant. This is also autosomal dominant except macula, which
No,
is
so
recessive. So this is
it's right here that lattice dystrophy is autosomal dominant, but for your information, macular dystrophy is autosomal recessive. All right.
yes, except
Acha,
macular
what are the
dystrophy.
other dystrophies which are corneal dystrophies which are autosomal recessive other than macular?
I have only this one. What is the other one is maybe CHED1 or
Yes, CHED
CHED1
and
maybe alvelino, one type of alvelino will also be
no.
autosomal recessive.
Any other candidate? Actually, this is
Gelatinous.
a question. Gelatinous,
Gel
yes. There is something. There is a mnemonic section in IUC. You can search mnemonic MNEMONICS in IUC.
Yeah,
So there is something called
I
max
see.
theta or something. Just basically
Map.theta. Yeah,
macular dystrophy, CHED,
yeah,
and gelatinous
yeah.
droplet dystrophy.
and Lesh is excellent.
Lesh is excellent. That's right. Wonderful.
Sir, I wanted to
Yes.
ask one question. Do we have to differentiate DALC with PKP on exam?
You may have to, because I was once standing next to the examiner for FRCS Edinburgh at Shankar Nethralaya when I was a fellow, and we had put a DAL case, and he did ask about this. So the answer to that is, this was Edinburgh, but I'm sure the answer will remain the same. And the answer to
Any
that,
tips how to do it? Any
yeah,
tips how
so
to do it?
yeah, of course. So you have to try and look for the interface. All right. So if there is a little bit of stroma left behind, you'll be able to see that interface between the host and the donor tissue. If the dissection is very, very near descemetic, it's extremely difficult to identify. But
Would number of stitches be of any help?
no, not really. Where I put 16 for DALK, I put 16 for PK.
Okay, thank you.
Yeah.
So only in the anterior segment, this OCT, sorry, in the topography, when we do the anterior segment OCT, we can see the cornea, whether it is full graft or the DALK is
yes,
there.
that would work. But clinically, if they ask you to identify, then you just have to say that interface. And OCT will actually show you the interface much better. So you're right about that. But if they ask, then yes, OCT. Otherwise, clinically, you have to just say that you have to look for the interface of the owner and donor and host tissue.
Yeah. Okay.
So wonderful questions. The patient has a BCV of 636 parts, is having significant photophobia, then I would advise a deep anterior lamellar keratoplasty, since the lattice is an epithelial stromal dystrophy and the DM therefore is predominantly uninvolved in lattice corneal dystrophy. All right. So here's another one.
Yeah.
Does anybody want to attempt this, please?
I can give it a go.
Please go ahead. Please go ahead.
So I'm not sure about the eye, but I'll just give it
Left eye,
a
left
guess.
eye.
It's probably left eye. It's the left eye of the patient, and I can see some punctate whitish lesions in the anterior stroma, and I can
You
see
won't
that
be
in
able to
between the
comment on anterior based on this. This is a diffuse photograph. Slit photograph only will tell you anterior. So
okay,
just
and
say
in
that
yeah, and in between the lesions, I can see that there is stromal haze as well. So I would like to examine the other eye, but my top differential based on this examination would be macular corneal dystrophy. The other differentials might be uh, granular dystrophy or other epithelial dystrophies.
Okay. So this is granular dystrophy. So it's your second differential.
Okay.
It's fine.
Okay.
I want you to look at a couple of things. One is, they say that granular dystrophy should have clear intervening spaces. So I understand your reasoning as to why you called it macular. But the other thing is that macular tends to often involve the periphery, whereas here you will see on the left side that the periphery is very clear. Where it is visible, that it is very, very clear. Even superiorly, the periphery is very clear. So the involvement here is predominantly central and mid-peripheral. And there are clear intervening spaces. I don't unfortunately have a macular dystrophy image in the presentation, but if I can close this presentation after we finish and I can show you the difference. So this one is granular dystrophy. All right. And the textbook term that is normally used is breadcrumb deposit. They say it looks like crushed breadcrumbs, so they call it breadcrumb deposits.
Yeah.
Inheritance pattern, granular dystrophy. I mean, Kaushik has already covered it, but
Yeah, it's a autosomal dominant TGF beta 1.
wonderful, wonderful. Histopathology findings.
So you will find hyaline deposits, and it will stain with Mason trichome.
Excellent. Management options.
So these patients will have recurrent corneal erosions, and so you will treat the recurrent corneal erosions as already mentioned. And once the recurrent corneal erosions are stable, then you would go for DALK or PKP.
Sure. Okay. So he's covered everything. Inheritance, autosomal dominant. I'll show you the histopaths on the next slide. Management options for the recurrent erosions, bandage, soft contact lens. If the lesions are very superficial, then you can consider excimer laser phototherapeutic keratectomy or a superficial keratectomy. And if the lesions are mid to deep stromal, then you have to go for a DALK. In rare cases, you may have to consider a penetrating keratoplasty. But if you ask me, I'm a corneal surgeon, I will always try to do a DALK, even if it leaves behind a few lesions close to the Descemet membrane. Long term, because the rejection rates are lesser, it's a much better procedure that way. So Mason's trichrome, as he mentioned, that stains the keratohyaline red. Okay, so since we were talking about mnemonics, this is the mnemonic for the formerly
I don't know.
classified stromal dystrophies. Remember that granular and lattice are no longer called stromal dystrophies. They are now called epithelial stromal dystrophies, whereas macular dystrophy is a stromal dystrophy. And the mnemonic is Marilyn Monroe always gets her men in LA City. So Marilyn Monroe is macular dystrophy, mucopolysaccharides that stain with always, that is Alcian blue, gets her men, granular dystrophy, hyaline that stains with Mason trichrome that we just covered, and lattice dystrophy, amyloid deposits, that is LA City is congruent. All right. So this really helps if you have a dystrophy case that shows up, because the likelihood of there being a dystrophy is most likely it will be Fuchs or granular lattice or macular. And then of course it could be EBMD or gelatinous or any of the others, but these would be the more common ones that would show up. Can somebody describe this investigation and let me know what we're seeing here?
Yeah, this is OCT picture of
OCT,
anterior segment.
macula,
No, anterior segment OCT,
yes.
anterior segment OCT of cornea,
Hmm.
which is showing the cornea graft has been done, and I can see that it is DSEC.
Wonderful. Descemet stripping, endothelial keratoplasty. Try to use the full
Yeah,
form.
Descemet
So time is
stripping.
short.
Yes,
Ensure that
Descemet
you know what you're talking about. So the arrows
Yeah.
indicate Descemet stripping endothelial keratoplasty lenticule. All right. So what are the
Lenticule,
indications
yes.
for Descemet stripping endothelial keratoplasty?
This can be like either this endothelial Fuchs endothelial dystrophy,
Yes.
or it can be post cataract decompensated cornea
Yes.
with bullous keratopathy.
Wonderful.
Yeah. Or if it is like post herpetic something endotheliitis which has happened,
Okay.
we have to replace the endothelium layer.
Okay. So because again there, if the endothelium has failed leading to decompensation, then you have to replace it. Correct. Any other indication? Maybe one or two more.
Endotheliitis can happen because of any condition. If
Ah,
it is full
endotheliitis.
corneal scar, deep corneal scar, no, not deep one. No.
You can't remove corneal scars with DSEC because you only remove the
Yeah.
Descemet membrane.
Yes. Yes. Yes.
Right. So
Yes.
if you
Yes.
have a deep corneal scar, DSEC will not work because it won't remove the scar.
Yes. It will not. Post herpetic endotheliitis.
Done. Herpetic done.
Okay.
Okay.
Then
so we've mentioned
endothelial dystrophies has done, and this is done. Infection done. So.
Okay, so I'll tell you. You mentioned endothelial dystrophies. There are two more endothelial dystrophies where a DSEC can be done. CHED and PPCD, posterior polymorphous corneal dystrophy.
Yeah, posterior polymorphous corneal dystrophy.
Yeah. And ICE syndrome. There as well, you can do a DSEC if
Did anyone tell TAS is also something toxic anterior segment syndrome?
Anterior segment syndrome. Correct.
Oh, okay, TAS.
I'm so sorry. Just
TAS will lead to the formation of to the condition of DSEC.
It may.
TAS.
It may. It may. Just excuse me for a second. I'm so sorry.
Sure.
My apologies. So last question, what is the difference between Descemet stripping endothelial keratoplasty and Descemet membrane endothelial keratoplasty?
Okay, so Descemet stripping endothelial keratoplasty also has some part of the stromal tissue with it. And Descemet, so it is a thicker graft. And Descemet membrane endothelial dystrophy is thinner, so it is only, so it is only Descemet membrane and endothelium layer without stroma.
Wonderful, wonderful. So in a DSEC, my apologies again. So a DSEC, the tissue transferred includes endothelium, Descemet membrane, and posterior stroma. And like she mentioned, the DMEC, only the endothelium and the Descemet membrane are transplanted. Remember that what is removed is exactly the same, Descemet membrane and endothelium. But because DSEC came earlier, at the time the concept of like replacement for like replacement was not there. So they decided to kind of graft the lenticule such that there would be some amount of posterior stroma. We're slowly moving away from DSEC in the cases where it is allowed, where we may only do endothelium and Descemet membrane transplant.
Yeah.
Can somebody describe this, please?
Sir, can I ask a question about the last slide?
Yes, please.
Is it possible that it may be in a case in OSCE clinical examination and he want me an examination of anterior segment to tell him if it's DMEC or DSEC?
You will be able to identify a DSEC fairly easily. So remember with the DALC, I was talking about that interface. When I mentioned that between the host and the donor tissue, there will be an interface. With a DSEC, you will definitely see the lenticule separately. So if I were examining for FRCS, I would not keep a DMEC because the DMEC is very hard even to identify. Because you remove a thin layer 15 microns, you put a thin layer 15 microns. Now 15 microns is not even, even with a slit lamp, you cannot resolve 15 microns. So you can't see it. So I would be very surprised if a post DMEC patient came up in the exam unless it was a failed DMEC. Because the idea should be, in an ideal world, it should be that you are able to see the obvious. So I would have kept a DSEC case, but I would probably not keep a DMEC case. So a DSEC is very easy to identify because you see the lenticule separately. The way you're seeing it here in the OCT, the same way you will see it on the slit lamp. But a DMEC is actually very hard to identify. Okay. So this stromal thickening that you see here, sorry, that's not the right term. The interface that you're seeing here, you will not see that in DMEC. Not very easily because there's no stroma. So there's no stromal interface.
Okay, sir.
Okay. So who's going to volunteer for this? Dr. Kaushik,
Yes,
please
sir.
let me know how much time we have. Because
Yes, Dr. Prabhat, there is no limit. You can continue.
Great. Well, wonderful. Okay. All right. Who was volunteering?
Yes, sir.
Yes,
Yeah,
sir.
please go ahead.
This is anterior segment photograph showing diffuse corneal haze, and there are multiple bullae
Yes,
central
please.
involving central of the cornea, and the two large bullae involving the inferior cornea as well. Underlying details are not clearly visible. There are no corneal vascularization, and there is no any circumcorneal condition.
Okay.
The rest of the details of underlying details are not visible in this case.
Okay. So what's your diagnosis?
It's a bullous keratopathy.
Wonderful. Wonderful. So just a couple of add-ons. There is superior scarring. That white,
Yes,
soft white that you're seeing superiorly is scarring. Okay. So it's a bullous keratopathy with scarring. And everything else that you said was all right. There's only one vessel that is there superiorly that is visible, but it's fine because I've not everted the, lifted the lid well. So it's okay if you missed that. So what findings do you expect in slit image? Just state the obvious. What are you going to see on slit image?
Some signs are obvious in this case, like bullae and the stromal
Slit
haze.
section.
And
Slit section, what will you see? That you've already mentioned. Diffuse image. Slit section, what do you expect to see?
In the epithelium, there will be epithelial bullae, and it can be stromal haze and endothelial cell.
Endothelial cell loss, stromal edema. One more
Endothelial cell.
finding. Yeah, stromal edema. The patient is a 60-year-old male, underwent cataract surgery, left eye 18 months ago, and there was no improvement in vision post the cataract surgery. So you have to intervene to, visually rehabilitate this patient. But are there any ocular investigations, ophthalmic investigations that you would do prior to intervening?
These came in this case.
Wonderful.
Because
Ophthalmic
like,
ultrasound for the posterior segment status. What else?
and the anterior segment OCT.
Yes. Why?
What is the way of like frequency of this ophthalmic ultrasound which you are using for posterior segment?
It's a 90 decibel. What I remember.
No,
Decibel.
90 decibel is the gain, no?
Megahertz.
Gain, yes,
Yeah.
gain.
Yeah.
So
I don't remember.
what is the frequency you are using for ultrasound?
Sir, I don't remember.
Any other candidate?
10
These are
meg
important things.
10 megahertz.
Yes, 10 megas. This
10
is
megahertz.
important to know.
Wonderful.
And
Wonderful.
Wonderful.
So the UBM is about 35 megahertz, and the ophthalmic ophthalmic ultrasound, the B scan is 10 to 12 megahertz. So remember that if you increase the frequency, you reduce the penetration. So that is why the UBM will only give you anterior details, where the ophthalmic ultrasound does not give you anterior details, but gives you posterior details. All right, so you have to remember it like that. You say, why ASOCT?
to check for the thickness, the corneal, the lesion involving, the corneal thickness and the endothelium and the layers of the cornea.
Yes, yes. Cornea done. Good. That what else? There's one more thing why you should
Anterior chamber depth and angle in anterior chamber.
Angle status. One more thing,
Angle status.
if you can. You're almost there.
What else?
So you can't see the lens. So you need to look at the lens status. So the ASOCT will
Lens.
give you the lens status also. All right.
Lens status.
Okay. So what surgery would you advise?
Sir, directly surgery, then because we start with the conservative, but if surgery, then keratoplasty, penetrating keratoplasty. This,
Correct.
if there is a.
In this case, I would advise penetrating keratoplasty because of the amount of scarring that is there. Otherwise, a DSEC can also be planned. So just for your information, there was a lot of synechia superiorly. So this patient, penetrating keratoplasty is the only option. Patient is aphakic. So this was aphakic bullous keratopathy. If IOL implantation is needed, in this case, it would be needed. How would you do the IOL calculation?
Sir, we can compare with the fellow eye, and in this eye, we use the
So for a DSEC, using the fellow eye is a great idea because you're retaining the anterior surface. But for a penetrating keratoplasty, I prefer not to use the fellow eye. I would suggest using what is known as a standard K. So you assume an average of 44 postoperatively. It's a fairly gross method because you cannot predict what will happen after penetrating keratoplasty. You can have 35 also, you can have 50-35 also, anything can happen. That is why, for the sake of law of means, you take a 44 for your IL calculation and you do off the IL calculation. But if you're doing a DSEC, then yes, using the other IK is a very, very good idea. So K1 equal to K2 equal to 44 diopters. For axial length, as obtained from optical or immersion biometry, optical may or may not give you a value here. Immersion is fraught with danger because you can lead to rupture of the bullae. So if you want to avoid a contact procedure, then use the axial length from the other eye. But you may also then ask the patient whether there was a difference in refractive error prior to cataract surgery as a child or whatever, just to cover all your bases. Can somebody describe this?
Yes, sir, I can
Yes,
take
sir.
it.
Oh.
Please go ahead.
Okay, it's anterior segment photo showing the corneal haze and a band of opacification horizontal between 9 o'clock and 3 o'clock with micro holes in between, and it's bearing the limbs. And there is also corneal opacification at the upper part of the cornea, and there is generalized diffuse haze in the body.
Can you give me a diagnosis?
It's a case of band keratopathy.
Band keratopathy. Okay, wonderful, wonderful. So the causes of band-shaped keratopathy there are ophthalmic causes and systemic causes. Ophthalmic causes It's often seen in silicone oil filled eyes, chronic uveitis, and blind eyes. Systemic causes hypercalcemia, hyperthyroidism. Treatment, chelation with sodium or potassium edetate. And you can also do a phototherapeutic keratectomy. In cases where the visual prognosis is very, very poor and the band-shaped keratopathy is otherwise asymptomatic, you may choose to observe it. On occasion, epithelial defects may develop where the epithelium over the band-shaped keratopathy breaks down. And in those cases, you would need to remove the band-shaped keratopathy. Or if you expect the vision to improve by 1 or 2 lines, then you should remove the band-shaped keratopathy. It is important to tell a patient with a silicone oil filled eye, if the retina specialist has not planned an oil removal, that the band-shaped keratopathy is likely to occur over time, reoccur over time, because the silicone oil is present in situ. Next
Achha,
question.
can anyone tell which patient will likely develop band-shaped keratopathy? If a 6-year-old boy or a 40-year-old male? Any candidate? Which person? Which
Boys,
person will?
The
boys,
6-year-old boy.
Yes. If the age is less, and specifically if they are aphakic, there is a high chance of getting this kind of BSK after silicone oil or any other disease. For even in after juvenile idiopathic arthritis, kids develop this
Yeah.
band-shaped keratopathy.
JIA is a very, very common cause. Juvenile idiopathic arthritis is a very, very common cause of band-shaped keratopathy. And those are patients who actually show visual improvement upon removal of the BSK. Can somebody describe this?
Yes, sir. I'll describe. So this is a picture of an anterior segment OCT showing showing the layers of the cornea with the Descemet membrane and endothelium detachment at the center.
Yeah, just say Descemet membrane detachment.
Okay.
I mean, it's a given that the endothelium has moved with the Descemet membrane. So it's a Descemet membrane detachment. Wonderful. So this has happened post-cataract surgery. In fact, in the infrared image, you can still see the air bubble on post-operative day 1.
Dr. Anirban, I have a question. What is happening to the PC, or what is there in the lower side?
So I think the
Below,
lens is the lens a little subluxated. I'm not sure.
No. Below the lens, below there is
Okay.
IOL. No, after the
Yes,
IOL, there
yes.
is a concave kind of appearance. What is that?
Yes.
What is that?
It's capsular distension syndrome, viscoelastic
Okay.
retaining behind the IOL.
Excellent.
And can there be any other thing like that? Like
I'm not sure, sir.
so sometimes, most likely this is capsular distension, but sometimes because of a mirror artifact, you can actually see the reflection of the cornea sometimes. So I am not saying that this is that, but this can, like, you have to keep that in differential also if there you are finding some concave like thing here.
Okay.
Dr. Prabhat, please.
Yeah. Okay. So you have this image of you have done a cataract surgery, and the same day when you see the post-op at say 6 p.m., you realize that there is a Descemet membrane detachment, and the OCT is showing you that because you have florid edema, you have 4+ SKs, and then you realize that there's a Descemet membrane detachment. So what are your management options, and which one will you choose and why?
So I think we should go for an intracameral either either air or isoexpansile gas.
Okay.
To replace the Descemet membrane to its place.
Reposition.
Reposition. Yeah.
Not replace. Yeah.
Reposition it in this place.
Okay. All right. So you mentioned isoexpansile gases. So what are our options in isoexpansile gases, and how much is the concentration of each of the isoexpansile gases?
We can go for 20% sulfur SF6, sulfur hexafluoride, or 14% C3F8.
Great. So it's the same concentration that the retina surgeons use?
Yes.
All right. And any precautions? Let us say you use...
We'll do a inferior peripheral iridectomy so that the pupillary block does not happen and the IOP rise does not occur post the gas injection.
Okay. One more piece of advice for the patient if I would like to give.
To lay down supine.
Yeah. Okay. And one more, that is avoid air travel until the gas bubble.
Yeah. Correct. Yeah.
Okay.
Is the gas
So
cell.
sorry, I have switched it. It's 20% SF6 and 12% or 12 to 14% C3F8. That's my mistake. And you may also choose to observe. For the record, this patient actually reattached in 3 days on its own. The next day when I saw the post-op, it had reattached. So that is an option. It's a valid option. If you see the same thing, if you see 1 week later, it's not a valid option anymore. But if you see this on post-op day 0, not even post-op day 1, then you may choose to observe the patient.
So how long should we observe, or like what is the criteria? Like how long should we observe before planning for a gas injection?
I would observe for about 48 hours or so, and I want to see the size of the Descemet membrane detachment reduce. The distance of the Descemet membrane from the remaining cornea and the size extension of the Descemet membrane detachment reduce. If this reduces and this reduces, then you may choose to observe. Yeah.
Okay.
Dr. Prabhat, I have one question, if you don't mind.
Yes,
Do you have any preference as far as gases are concerned for the AC? Because I was of the understanding that C3F8 remains in AC for quite longer as compared to
much
SF6.
longer. So yeah, I mean, we use SF6, but I've often seen that it's only the chronic DM detachments that require even SF6 in my opinion. Otherwise, air works quite well for an acute
Yeah.
early Descemet membrane detachment. Yeah.
Okay, thank you.
Sir, it's for 1 week we choose this gas, and after 1 week, what we should do for patient?
No. So I just use 1 week as an example, but
Yeah.
what you mean to say is where there's a chronic detachment, is that what you're trying to say?
Yes, sir. Yes, sir.
All right. So there are a couple of maneuvers you can do. There's something known as a suture desmetopexy. So if the desmet has been detached for a long time, it will start to curl like this. So you have to try and uncurl it. All right. And then at that point, you will have to kind of take sutures through the entire thickness of the cornea. Normal corneal suture is about 90% thickness. This will actually be 100% thickness, and you try to use air to unfold the Descemet membrane like that. I don't know if you can see what I'm trying to tell you. So there is air here, and you try to use it to uncurl the Descemet membrane, and then you also take a full thickness suture. So you use that suture to hold the Descemet membrane in place. So that's known as a suture desmetopexy. So that is something else you can do. And if that also does not work and the cornea decompensates, you have no choice other than desec or demec. All right.
Okay, Dr. Prabhat,
Thank
I
you,
had
sir.
a question. Like the fluid beneath the Descemet detachment, it was a little opaque. So what can be the cause of this? Because I have not seen, like, the fluid is usually the same reflectivity of the like aqueous. So
Yeah.
what is the cause? Is it visco or something, or what is that?
No, there was no visco. This had happened during hydration of the side port actually. And this is beyond the scope of an FRCS exam, but since this discussion has come up, I will share it anyway. When you look at the posterior stroma, you're seeing
Yes,
that
some
it is split.
lamella or separation
Yeah,
like
it
that.
has
Yes.
split. So I believe that some of the posterior stroma had actually detached and flown into that area, which led to the granular hyperreflectivity.
Okay. No, so is this described or something? Because it is something I saw, like this is for like new for me.
Yeah, it's new. It was new for me also at that time. So we've actually submitted this for publication. We're just waiting for a response from them.
And also some people have done this full thickness puncture. Like if it is not settling after you put gas, you can put full thickness corneal rupture. So the corneal like penetrating points so that the
Yeah,
fluid comes out.
it's called venting
Like,
incision. They used to
yes,
do it.
bending.
They used to do it for DSEC grafts also to attach the lenticule. So what
Yes,
we
yes.
do is I'll describe it in terms of the DSEC graft because that is something I understand more. So this is your DSEC graft. It's attached to the stroma, and through the stroma you put a full thickness incision that is kind of ending here, just above the DSEC graft. So and then you kind of squeeze that area. So when you squeeze that area, the interface fluid flows out from the incision. So that you can do here also, but
Yes,
I'm
yes.
not advised doing it because the other options that we have described, air, even observation in some cases, air, C3F8, SF6, suture desmetopexy, DSEC, DMEC, they usually cover all your bases.
And also, this is a quite common scenario. Like when you hydrate the main wound or side wound, sometimes the fluid actually passes through the between the descemet and the stroma. It
Yes,
is like not very uncommon to have
yes,
descemet detachment during the hydration itself.
yes, yes. So, but what we've come to realize is that normally this was an exception, but normally the descemet membrane detachment that happens during hydration is fairly localized. So you'll see the descemet membrane flutter like this, and then you have a hydrated side port, and it'll just come back and reattach because it is a tendency of the descemet membrane to curl outward. So most of those, not all, but most of those localized attachments that you're mentioning, they tend to reattach on their own, and often you don't need to even put intracameral air at that point.
Yes.
But that requires a healthy endothelium. Otherwise, a lot of these patients, even with the keratometry, the descemet membrane detaches, and you'll continue to see the detached descemet membrane for many weeks until finally it will fall back on its own. So next scenario, do I have a volunteer?
This is a picture of giant papillae in the upper tarsal conjunctiva,
Wonderful.
the lower picture.
Hmm.
And the upper picture is showing Trentaz spots with
Yes.
some punctate epithelial erosions.
Correct. Correct. So do I have a diagnosis?
Yeah, it is vernal keratoconjunctivitis.
Wonderful. So when you have a patient with vernal keratoconjunctivitis, ask for history of redness, itching, and you'll see that muddy conjunctival appearance because they keep on rubbing, so that leads to diathesis, that is blood cells leak out of the vessels because of frequent rubbing, and those leads to hemosiderin deposits on the conjunctiva. Therefore, you have that muddy conjunctiva appearance. So you will identify the patient from 6 feet away. The patient will walk into your clinic and you'll know, all right, VKC. You don't need to think.
Yes.
All right. So you ask for
Yeah.
history pertaining to specific allergens, dust mite, or just whether there's exacerbation. In India, the exacerbation tends to happen in summers because we don't really have a spring. But otherwise, VKC is also known as spring keta.
Yeah.
Associated systemic allergies, dermatological allergies, rhinitis. Most of them will have that. A lot of them will have that allergic line here. They'll keep on complaining of history of sneezing. Some of them may even have associated asthma. Frequency and duration of previous episodes. Recurrent use of topical steroids or other medications. Treatment with a taper of topical steroids. You must always give topical steroids for a limited duration with a set taper, the way you would give it post cataract. With topical antihistaminics with or without mast cell stabilizers, lubricating eye drops, and cold compresses to act on the inflammatory component. Rule out systemic association, consider referral to allergists, and advise avoidance of known allergens.
Yeah.
This is one of my favorites. Can somebody describe this? You have 3 images. Try to describe them together if you can, or one by one, whatever.
Yes, sir, I can take it.
Yeah.
It's a case of post-herpetic corneal graft rejection.
It's a corneal graft. It's very difficult to say whether it's a rejection or a failure, but I would err on the side of saying failure because the rejection is reversible, whereas a failure is irreversible. So just call it a failed graft. It probably be more sensible. You more likely to get it right. This is actually a failed graft only. So yeah. Yeah. What else? Are we seeing anything else other than the graft?
Okay, I see it's a pseudodendritic ulcer. With most of fluorescein stain, I think it's herpetic. It's herpetic ulcer.
Yeah. So what
And
can I say? It's a dendritic ulcer, but why pseudodendritic? Because you've got the terminal bulbs, you've got everything. So
yeah, okay.
So this is a
dendritic ulcer.
dendritic ulcer. All right, just you can call it a dendritic ulcer. Technically, it's a dendritogeographic ulcer because it has width. A dendrite will only have length. A geographic ulcer has length and width. So you've got dendrites here at the ends. You can see the terminal end bulbs also in the middle image, and you've got that width in the central portion.
Rose Bengal stone.
Right? So it's a
Okay.
dendritogeographic ulcer, or you can just call it a dendritic ulcer and keep it simple. What is that
Okay.
specific sign that you're seeing in the third image, the image on the right?
Rose Bengal staining the necrotic tissue.
Yes. So rose Bengal staining of the edges and the base is staining with fluorescein. That's a classical double staining pattern of a dendrite.
Okay.
All right. And that happens because fluorescein stains areas of denuded epithelium. Rose Bengal stains devitalized epithelium. So swollen cells will get stained with rose Bengal. Wherever there is no epithelium, that will get stained with fluorescein. So how would you treat this? You've got a dendrite. How would you treat it?
Okay, I will prescribe for the patient systemic antiviral as a cyclovir. Okay, and the topical antiviral and the cover of topical antibiotic.
Okay, so I would not give systemic antivirals for this. The standard of care just remains only topical antivirals. So in India, we have acyclovir 3% ointment, so which is what we use. Whichever country you're from, whatever is available, it would be great if you mentioned that, because that just shows that you're dealing with these cases. So topical antiviral ointment 5 times a day. In our case, as I mentioned, acyclovir 3%. Topical lubricants. And I would review this patient in 3 days and then at 1 week. And normally we continue this for about 14 to 21 days. We prefer not to continue it beyond 21 days because acyclovir in particular is quite toxic to the epithelium. So you can develop toxic epitheliopathy as a complication of long-term use of topical acyclovir. This does not require systemic acyclovir, particularly for herpes simplex. For zoster in an immunocompromised patient, non-resolving multiple pseudodendrites, like you mentioned pseudodendrite, those you may consider systemic antiviral, but here it's not required.
But for securing
Is
of
it not in the is it not in the criteria that if there is a herpetic eruption in the corneal graft, then we have to give a systemic antiviral?
No, it's not. It's
And
not.
that also for long term?
No. That is for endothelial and stromal.
Okay. So
Okay.
if it is
And
epithelium one,
what happens is that endothelial and stromal are far more prone to recurrence than dendrites. And therefore, the role of prophylactic long-term antiviral comes there, not here.
and then he will be kept on steroids because he has a peak, he has a corneal graft done. So there would be chances of getting
graft,
recurrence
yes,
again.
correct. That would be the case, but this graft has already failed.
Okay.
This graft has already failed, so you don't really need to continue the steroids.
How long does herpes needs to be stabilized before going for a graft?
You want me to answer this question, or
Yes. Because this is one of the questions I was asked in one of the exams, the RCOF exams, and I went with 3 months, and they said no.
No, they said no.
No.
Yeah, so just say 6 months then. 3
6
months
months.
too early. Yeah.
Okay. Thank you.
Can somebody describe this? Fairly regular investigation. A lot of you must be dealing with it, particularly if you're refractive surgeons.
Yes, sir.
This is a pentacam.
Yes.
One person, please.
Okay, this is a pentacam picture showing 4 maps.
Yes.
And showing the this topo in the first picture as this looks like a case of keratoconus, but K2 is like 50.9 and K1 is 46.6. Then if I K average is also 48. So this then there comes the cornea posterior curvature. Okay. And then pachymetry is cornea is quite thin. So this goes in the category of keratoconus. There is in the first picture I can see that there is a bow tie configuration with inferior steepening, inferiorly displaced cone, and I'm sure the IS minus superior one will be greater than 2. And then
Just trying to
in the
describe the image. I mean, it's
anterior
okay.
elevation,
Yeah, you got it
anterior
right.
elevation is also shown plus 14. So
Yeah.
this comes in the category of keratoconus.
Yeah.
So why is it
Grade
not PMD?
2.
Why is it not PMD?
Grade 2. Because it is in the central 4 mm, and pellucid marginal degeneration goes after that. I mean, it will not be in the central 4 mm.
What is the relation
And
between thinning and keratometry in PMD and in keratoconus? Like corneal thinning and keratometry changes in keratoconus versus PMD.
pellucid marginal degeneration is against the this against the rule.
The location of thinning and keratometry changes. What happens in keratoconus and what happens in PMD? Are those in the same place in PMD? The thinning and keratometry changes.
The back elevations in keratoconus, the posterior elevation.
In PMD, the thinning is inferior to the maximum protrusion, whereas in keratoconus, it's at the same place.
Yes.
Precisely.
Yes.
Precisely. So just, completing the discussion of PMD, because before we move back to keratoconus, I think everybody covered everything. So I'll just put it together. There's a crab claw appearance on topography on the axial or sagittal curvature map. Just remember this goes like this. All right. So
Yeah.
there'll be this band going inferior on both sides. That will be steep. That is PMD. The cornea will actually show something of a pot belly appearance. So you'll have this inferior steepening, and inferior to that, you will then have the area of thinning. Okay, inferior protrusion, and inferior to that, you'll have the area of maximum thinning. Whereas here, when you look at the lower two maps, where that 448 thickness is mentioned, and next to that, in the posterior elevation map, there's a thickness of about 34. They're almost at the same spot. So the area of maximum elevation corresponds with the thinnest point in keratoconus.
Okay.
All right.
Okay.
So when I look at this map, I would look at the QS, that is the quality score. That is okay. So this is a reliable map. Then I would look at I normally don't describe the anterior elevation because it doesn't help much and it just distracts and wastes time, particularly for exam. So I look at corneal thickness in the range of 448, 477, 499 in the central and inferior paracentral area, corresponding posterior elevation 32, 34, etc., etc. Coming to the sagittal curvature, there's an asymmetric bow tie with skewing of the radial axis with inferior steepening. K146, K2 50, K max 54, and thinnest local 443. This is most likely a case of keratoconus. That's how I would describe it within 1 minute. So to save the remaining 5 minutes that you have for your cornea.
Okay.
Okay. So I'm done with the slides. I would just recommend that if you can, please try and read specular microscopy, ASOCT, topography and tomography, corneal dystrophies, corneal ulcers. And from the CHUA website, I would strongly recommend going through the candidate 211 experience. So the doctor who has written up this experience slide, her write-up, her husband also appeared and cleared the FRCS in the same this thing, and she has mentioned it there. And they actually took the pains of noting down every topic that might occur in the exam. So once I read her experience, I stopped reading the other experiences because it was so comprehensive. I'm not saying that's what you should do, but I am saying that's what I did. So I'm going to share that paper on the group if that's all right with Dr. Kaushik and everybody, because it'll really summarize every topic that you need to go through, not just for cornea, but for every subspecialty. And if there are any specialists listening in, if there are any subspecialists, I would recommend that, you bring yourself down to the PG level and forget for a while that you're a subspecialist ophthalmologist. Forget about retina, forget about cornea, whatever you have specifically been trained in for 2 years, 3 years, whatever you've been practicing for 4 years. Bring yourself down to the level of Kansky or whichever book you read during your residency so that you have comprehensive knowledge across all 8 subspecialties. And if there's anything else, I'm on the Telegram group and my number is there, so you can contact me. Thanks to Dr. Kaushik, we've already also kept a class on strabismus on the 21st, which is next Wednesday, which is also something that I practice. So I hope that everybody will benefit from that as well. If there's anything else, please let me know.
Thank you, Dr. Prabhat. It was a wonderful class.
Okay.
And all the images are like, they can be asked in exam. They are very important in FRC's exam. So everybody should read. And also, as you said, specifically the people who are practicing other specialties, they should focus more on the specialties which they are not seeing.
Absolutely. So I
because
didn't
this is
read
a
Cornea
comprehensive
I didn't
bit of
read
exam.
Cornea for FRCS. Yeah. So.
Yes. So I am a retina consultant. So, but I do have interest in all specialties. So we need to keep on reading because there are so many things are happening in every specialty.
Yeah.
And thank you, Dr. Prabhat. There is another class, but if you want to take more classes, we are open to that, and definitely the candidates will benefit from that.
Yeah, I mean, I'll come up with some more material for Cornea, and maybe in a couple of months we'll repeat it. I think there's an FRCS exam happening next month, so I hope that this was good enough for that. Prior to the
Yes.
September attempt in Mumbai and Delhi, I'll take another one for Cornea, maybe in August or something like that. Unless you want me to, because I'll need to put up new material for Cornea in the interim. So that takes a little bit of time.
Yes. Please take time, but we will like to have more classes from you.
Wonderful. Thank you so much. Thank you.
Thank you so much. Thank you. Good day.
Thank you. Good night.
Thank you. Good day.
Thank you.
Thank you.